Okay, chapter 14, part 2. So, the physical laws describing blood flow. So this is not just blood flow, this is any fluid flow. Okay, the difference between the pressure, so the pressure on one end of the tube versus the pressure on the other end of the tube, okay, divided by the resistance. Okay, so if there was no difference in blood pressure between one end and the other, there's no flow. Okay, all right. The other equation that's probably more relevant, okay, the way to measure resistance. So this term on the bottom is actually this, okay? So the longer the blood vessel, the more resistance, okay? And the viscosity of the blood, okay? So the thicker the blood, the higher the pressure, okay? So if this value increases, then the resistance increases, then the blood flow decreases, okay? So if you think about it this way, the more gooey the stuff is, okay, the harder it is to pump, right? And last but not least, the R4 value. Okay, this is huge, okay? So if you double the radius, this is 8 times, 16 times actually, not 8. So if you double the radius, the resistance goes down 16-fold. Okay? Okay. So Newton's law as a physical constraint, so change blood pressure R4. Okay. So blood flow equals MLA. Okay. So there you go. Here's the difference between the two. You can see the differences here. Okay. So here, if you double the diameter from normal, okay, the blood flow 16, the resistance is 1/16 of the radius, okay? So here you can see the same thing, okay? How much harder it is to go through a small tube than a large tube. And that is a very big difference. So vasoconstriction and vasodilation is going to be the main thing that controls pressure and resistance, okay? Okay, so here, okay? Okay, here you can see the difference in pressure, okay, in the left ventricle, the large arteries, the elastic arteries, and then here is the the arterials, and small arteries and capillaries, and eventually venules and veins, okay? All right, so, okay, next term is something called TPR, okay? Total peripheral resistance, okay? The total peripheral resistance is the sum of all the vascular resistance in systemic circulation, okay? Okay. So, first concept, the blood flow to organs run parallel to each other, so change in resistance within one organ does not affect the other. So they run in parallel, which means for the most part, okay, expanding A doesn't do anything to B, okay? So increasing blood flow to your kidneys doesn't automatically decrease blood flow to your liver or something like that, okay? Okay. Okay. Um, automatic control of blood flow. Okay, the sympathetic nerves obviously increase cardiac output and increase total TPR. Okay, so I know this sounds backwards because if you're trying to pump blood everywhere, why do you want to increase total peripheral resistance? Why do you want your arteries to constrict? That seems backwards. But think about it this way. You're not trying to get blood everywhere. You're trying to get blood to certain places and only certain places in the muscles that you're trying to run with. So you want to increase TPR, okay, into the arterioles of the viscera, which constrict them, okay, okay, and like the skin, etc., etc. So, okay. Okay, skeletal muscles. Okay, so there you go. Okay, you read all this through. Okay, the acetylcholine stimulates vasodilation, limited digestive tract, external genitalia, and salivary glands. Okay, step forward a little bit. Okay. Blood flow from to the heart and skeletal muscles. So the coronary arteries supply blood to the massive amount of capillaries. Okay. Unlike most organs, blood flow is restricted interstitially. Okay, because the heart is actively beating. Unlike most organs, the blood flow is constricted. The cardiac tissue has to store the oxygen, and that's what myoglobin is. Okay. 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 Um, the regulation of coronary blood flow, the norepinephrine from the sympathetic nerve fibers, okay, stimulates vasoconstriction, which raises vascular resistance at rest. Okay, the adrenal epinephrine stimulates vasodilation and decreases vascular resistance during exercise. So now you have a bigger difference between the two ends. Okay, and that helps blood flow. Okay, so this is an angiogram. Okay, so you can see the blockages that are there. This is a pretty good heart. I don't think this is an actual disease heart. Like if it's a disease heart, there's a narrowing of the tube somewhere. I don't see it. Maybe it's there. Okay. Oh, where the little arrow is. Sorry. Got it. See that arrow? The little blockage is right there. I was looking for a little dark area. Okay. And this is a cabbage graft, coronary artery bypass graft. You can see the bypass. Okay. Okay. Exercise training, increased density of coronary arteries and arterial capillaries. So increase production of nitric oxide to promote vasodilation. Okay. Regulation of blood flow through skeletal muscles. Arterials have high vascular resistance at rest. Okay. Due to adrenergic sympathetic stimulation. So even at rest, skeletal muscles still receive 25% of the body's blood supply. Okay. Okay, so you can see like the one of the cool things, the difference. This is 1 liter per minute. Okay, the heavy exercise is 20 liters per minute. There's a 20-fold difference. Okay, increasing metabolic rate of exercise muscles, reducing intrinsic vasodilation. Okay. Okay, so I'm going to skip ahead a little bit. So when you exercise, your cardiac output can increase fivefold, okay, just due to increased cardiac rate. So what's going to happen, okay, is your heart is going to pump harder and faster, okay? So actually, I like using these graphs better. Okay, so your cardiac output is dependent on heart rate, the cardiac rate times stroke volume. Your cardiac rate will go up, your heart will beat faster, okay? That will pump more blood, and that will force more blood back to the heart every second, and so your stroke volume will also increase. Not only do you pump harder, you pump more or not only do you pump faster, you pump harder, you push more blood out with every stroke. Okay, and that increases the blood flow to skeletal muscles. Okay, the sympathetic vasoconstriction into the viscera. Okay, decreases blood flow to everywhere else, therefore increases blood flow to the muscles. Okay, metabolic vasodilation in the muscles causes more blood to go to the muscles as well. Okay, so let's see. The sympathetic adrenal system affects up these that improve venous return because again, you're pumping more blood, so you have to have more blood return to the heart. Okay, so increases blood volume. Okay, and deeper breathing. Also, when you expand your chest and stuff more, it actually increases the venous return because you're pushing on your when you open up your lungs, you're pushing on the veins there. Okay. Okay, so brain is not a place where you can handle changes in blood pressure. Okay, so the cerebral circulation is held to about that 750. Okay, because your head is your well, first of all, your brain is really soft, squishy stuff, and two, it's locked into your skull, so you can't have increase in blood pressure because uh, that can cause an aneurysm or cause you to stroke out. So that is about how it usually about causes it. Okay, so here that keeps it about constant. Okay. Okay. That said, patterns can change a little bit, um, but that's very little. But you can measure it, and that's like measuring brain activity. The cutaneous blood flow, that you should probably read on your own. Okay, that's really easy to understand. Okay. So blood pressure, okay? Okay, so it's affected by blood volume, stroke volume, PPR, and cardiac rate, okay? Okay, so I like talking through pictures. So here, okay, if blood is coming here, you have a clamp here, you have increased pressure here, okay? Before the clamp, there's increased pressure. After the clamp, there's decreased pressure, okay? And this will become more relevant when we talk about kidneys. Okay. Okay, the blood pressure of the blood vessels is related to total cross-sectional area. Okay, the capillaries, the blood pressure is low because of the total cross-sectional area. The artery is high because of the small cross-sectional area. And you can see that here. Okay, here's the area. Okay, the most of the area of the blood vessels is actually in the capillaries, and therefore you see the blood pressure drop dramatically when it comes to the capillaries. Okay, and then it goes to the veins. Okay. All right. The baroreceptor reflex. Okay. Activated by changing the blood pressure detected in the aortic arch and carotid sinuses. So you can measure pressure there. Okay. So these are really kind of the quick reflexes and stuff like that. So, um, like if you go from lying down to standing up, okay, there has to be changes in blood pressure because now you're going from like lying down is the ultimate of low blood pressure because everything's even. When you stand up, there has to be an increase in blood pressure because now blood is going to your brain. Okay. So blood pressure measurements. I'll let you guys read that on your own. Um, you guys should be able to measure blood pressure. I think lab number 6 actually deals with measuring blood pressure. But basically, let's go through this really quickly. Okay, so what you're listening for when you're listening for blood pressure is you're listening for turbulence, really. Okay, so you shut off the artery here where there's no blood flow, and then when you start to hear sounds, the sounds of cardiac cough, they're going to be turbulence. The cells are all banging into each other because they're going through a very narrow tube, and there's not there. The flow is no longer something called laminar, okay, where everything flows in lines. This is turbulent flow. They all bang into each other because they go from a thick tube to a very narrow tube, and they can't fit together. So they're going to bang into each other, cause turbulence. That's what you can hear. Okay. And then by the very end, you restore laminar flow, and that flow is like straight lines, and therefore they don't bang into each other anymore, and therefore you don't hear anything anymore. Okay. Okay. Your pulse pressure, okay, is the difference between systole and diastole. Okay, the pulse pressure is the pressure of your pulse, literally, how much difference there is between pumping and relaxation. Okay, so that is an reflection of stroke volume, or how hard your heart is actually working. Okay. Okay. MAP, or mean arterial pressure, okay, is the average, your average pressure in your arterials. And so this is like, if you want to represent your blood pressure as one number, that's the mean arterial pressure. It's significant because it's the difference between the arterial pressure and venous pressure that drives the blood in the capillaries. It's calculated as diastolic pressure plus 1/3 pulse pressure. So I'm going to show you a different way of calculating this that makes more sense to me. Okay, but you can use that equation too. Okay, so the way I think about the mean arterial pressure is the average pressure that's in the artery. Your artery is going to be either in systolic or diastolic. Okay, systolic is going to be shorter, diastolic is going to be longer. So diastolic will take more time, and systolic will take less time. So so the equation, systolic pressure plus that's the one I use. So systolic plus diastolic, two times the diastolic divided by 3. Because I always think this consistently 1/3 of the time and diastole 2/3 of the time. So that's going to be the mean arterial pressure. Okay, but I can easily use math and convert that equation to the same equation that they give you in the textbook right there. Okay, they mean the same thing. Okay. Okay, now I show you, I just did the math, and I showed you, like, I can go from this formula that I use to get to that formula that I use, okay? Or that is in the textbook. And they'll give you the same number, so don't worry about it. Either one is fine. Uh, okay, hypertension, by definition, is high blood pressure, okay? So, okay, this is normal. This is pre-hypertension. Stage 1 hypertension is 140 to 160, okay, or 99 to 100 millimeters mercury for diastolic, okay. Type 2 or stage 2, sorry. Okay, the possible causes of hypertension, you can read that by yourself, okay. Okay. The nature of the hypertension, okay. The vascular damage within the organs. First of all, your heart is pumping too hard. Okay, that causes stress on your heart. The ventricular overload to inject blood will cause abnormal hypertrophy, leading to arrhythmias and cardiac arrest. Okay. The treatments for hypertension, you can read yourself. I'm sure some of you guys are more than aware of a lot of this stuff already. Okay. Okay. Preeclampsia, formerly called toxemia of the pregnancy. Okay. For 8% of women worldwide who are pregnant beyond their 20th week. So new onset of hypertension. Okay. But differs from gestational hypertension by evidence of damage to organs. Okay. Thrombocytopenia. So and proteinuria are present. This is actually one of the ways they measure it. Okay. So swallowing producing edema and swallowing feet, hands, and legs. I'm sure some of you guys have probably experienced this. Anyway. Okay, so this lasts until delivery of the child. Okay, circulatory shock occurs when inadequate blood flow to match oxygen usage. Okay, so shock. Hypovolemic shock when there's too little blood volume. Okay. Okay. So your body is your heart and your lungs. Everything else is secondary. Okay. Okay. Septic shock. When we cover septic shock, we cover micro. Septic shock is when all your blood leaves and leaks through your capillaries to fight infections, and that causes septic shock. Okay. Yeah. Okay. Congestive heart failure is when cardiac output is um, not sufficient to maintain blood flow. Okay. Okay. There are two sides of the heart, so there are two types of heart failure. Left side failure raises left arterial pressure and produces pulmonary congestion. Okay. The right side failure raises right atrial pressure. Okay, and produces systemic congestion. Okay, so